required to have that blood test.
Right.
Then that second test could follow a week, 2 weeks, a month later or
About
something?
2 weeks after 2 weeks.
Okay.
Because what we, or I believe what it, this is what
I know, I need to get,
is that some of the, some of the can be done right away, some of the metabolic tests can be done right away, because knowing about the results changes in my life-altering event. Others of the metabolic diseases or whatever will not show up and will not develop until about 2 weeks.
Gotcha. So that's interesting. Interesting. So you're saying that's a purposeful delay because there's things that may be identified later in baby's development that at first initial test may not. Wow. That's interesting.
And we run ASTHO.
29. So we're doing over 40. We do the required. I think the organization that says that. And I think it's the American Medical Association, but I'm not thinking it's right either.
There's some sort of newborn, the March of Dimes.
Yeah, March of Dimes really pushed heavy to get our. We, up till 2004, we were screening for 4 tests like sickle cell and a few of the more, I guess, what we call the more obvious tests. But we expanded that in 2005 and added this gamut of what. 29, including the hearing test, but as a result of the equipment we have, we went ahead and tested for additional 15 or so tests. Not required, I guess, but we have the capabilities with the apparatuses and the screen systems we use that we go ahead and screen for them. But it's interesting to say that you do a second round because of scientists believe that there's things that develop after. Empathy of the week. And ours by law, I think our law says you have to have this screening for 72 hours. Our statute says you must, all babies, whether it's midwife, hospital, however the baby's born, that blood has to be screened within them.
All right, welcome back. I had a deep dish pizza, Chicago style. Very good.
Where?
Difficulty like
left, and then you go right on what's the street? Wells and Hubbard. That's it. Very good. Like I said, if you go left, there's quite a few options over in that area on this side of the river. Any recommendations where we should not go back to? None? Okay, that's good. Everyone had a good experience, sounds like. I want to welcome back on the phone, especially Donna Moore, Pat Bedell, and Robert Breck. Welcome back. Any other CFOs? We'll get to our federal partners in just a minute, but other CFOs that have called in? Okay. And now we move to our facilitated dialogue, easy for me to say. Really appreciate the fact that our federal partners did step up to this. We have Terrence Perry and Randall Nielsen, who met passingly, and Jim will introduce them. We also have, this year, our planning committee really encouraged us to reach out to HRSA as well. So we have some folks from HRSA joining us over the phone, just because that's a newly expanding area of interest for us. So that's great. Really appreciate all our federal partners taking part in this, and we hope to just have a good, rich, open dialogue, part brainstorming, part troubleshooting, part talking about what's working and what isn't. Most of you know Jim Pearsall. I'll just take the opportunity to introduce him again. He is in his 7th year as Chief Program Officer, so he's one of the chiefs at ASTHO, overseeing the performance team, which includes me, Katie, Rivka, Allison, and others. Performance oversees a portfolio of projects on accreditation, performance and quality improvement, research and evaluation, leadership, workforce development, and health informatics. Quite a list. As a member of the ASTHO executive team, Jim plays an active role in supporting health policy and public health programs affecting state health agencies, so we really appreciate his expertise in leading us off. Jim?
Thank you, Carl. Welcome back.
And I'm going to try to keep us engaged after lunch with a little bit of energy as we go through this, and I'll ask my colleagues to do the same. I sort of envisioned myself doing this as like a Jimmy Kimmel kind of sketch, you know, going in. And sadly, I have in my room this giant floor-to-ceiling mirror. Casually glanced over, and I said, you know,
Jimmy didn't glance back.
I was dodging my own glance. It was a Medusa-like experience.
Yes.
Then I thought I was really looking more like a bad Jay Leno.
Yeah.
Then I came down here in my casual attire with my sophisticated dressed colleagues here. And I'm sure our colleagues on the phone are well-dressed today, too. So I'm feeling more like a used car salesman now. So, but they can talk a mile a minute. So I think I'm in the right uniform and in the right role. So I will just do this like a used car salesman. With us is Randall Nielsen. Randall has introduced himself, I think, a couple of times last night and today, from CDC ASTHO. And so he is their internal financial wizard, you know, who really helps them understand their award, their allocation. Remember that a few years ago, ASTHO didn't exist. It didn't have really a funding stream other than personnel lines. And now with the Prevention and Public Health Fund, we have a NIFI program, which is sort of their signature program, and touches every state, I think, but one. And it's just really a great opportunity for us to have an infrastructure source of funds, state public health, to help knit together the pieces that really make public health work across the country. So Randall, we're really pleased to have you here, and thank you for joining us. Aaron is 3 weeks into his acting role in PGO, and so he has been with PGO in the risk assessment side of the compliance side of PGO, which was really, I think, internally focused, if I'm not mistaken. A133 activities. And so prior to that, he was doing strategic planning within the area, and then he's worked over the years with grants to states over time. And so he brings sort of the CDC business office, if I could put it that way, perspective to our conversation and discussion today. So I think the mix of these two gentlemen from CDC is going to really help us deal with that part of the conversation. At this time, I would like to turn to the telephone, and I'm wondering if Jackie Whitaker, John Gallico, and Rick Goodman are on the line.
Well, yes, you've got a couple of well-dressed people here, too.
Well, we can tell just by looking.
Yes. This is John Gallico. I'm the director of the Division of Grants Operations at HRSA. And with me I have Jackie Whitaker. She's a team leader and senior grants management specialist that focuses primarily on health professions grants.
Awesome. Thank you very much.
Rick Goodman may be able to join us a little later. He is the Deputy Associate Administrator for the Office of Financial Assistance Management.
Super. So I want to double check, John. Are you in the health professions branch or in a broader area of HRSA?
I'm in a broader area of HRSA. We originally had planned for James King to join you. He's the Grants Management Officer that focuses strictly on the Health Professions Bureau. He's unable to make it today, so Jackie and I stepped in. I'm responsible for grants operations for all of HRSA. And Jackie does focus on health professions grants.
Great. I do think the audience here, who are chief fiscal officers from state health agencies, will also be interested in the MCH block grant part of the conversation. So something else to keep in mind. I'll come back to you in just a moment, John, but I wanted to ask each of our presenters to tell us then just a little bit about your interests and what you think are some of the topics you might want to address today. I've got a laundry list, but this will just be a starter list from your perspective.
Good afternoon. Again, I'm Randall Nielsen, Financial Officer for ASTHO. And before I begin, if I could just ask, I know most of you are NIFI recipients. Is everyone in the room familiar with the Office of State, Tribal, Local, and Territorial Support? Is there anyone who? Show of hands. Okay.
I might have one or two actually can raise their hand. Just to keep you honest.
Well, so ASTHO, in a nutshell, ASTHO's charge is basically threefold. To improve health department capacity and performance, develop assessment and capacity building tools and which is part of my purpose of being here today, is to engage still health officials with CDC, to serve as a conduit of information as well as a mechanism for expanding discussion, ideas, messaging, basically just interacting with all parts of CDC. That's a big charge. The themes that I've really picked up on that I think have the most alignment with some of our programs and projects are EPHF, number one, the impacts of that immediately, but also the long-term prospects of that for the benefits that it could bring to your health departments. Administrative shortfalls, the challenges of funding science and program delivery through categorical funds, as opposed to a more generalized approach that might make funds accessible for possibly focused administrative support. Fee and revenue service recovery. Fee recovery cost recovery is something that in my line of work I'm learning about from you guys. I apologize somewhat. I feel sometimes I'm drinking from a water hose at the moment because there's such a huge amount of information, different situations for each state. It's all very helpful to know, and one of my responsibilities is going to be to take back the breadth of the challenges that you guys have to our office. Probably most important, though, is return on investment. I see that you guys recognize that as critically as we do. There is a big role to be played with ROI in terms of funding grants in the budget environment that we have now. As funds are narrowing, ROI is going to be a great determinant of how we put those funds out. So those are major themes that I see. I look forward to answering any questions I can. I look forward to learning more from you guys in the next day. So thank you for having me here.
Good afternoon. I'm Terry Sperry, as was stated earlier. I guess a couple of things from my perspective was mentioned earlier. I've been in the job about a little over 3 weeks, trying to make sure we felt that it was important that the Procurement Advance Office did attend this meeting, because we wanted to ensure that you all knew that we consider you all a very important partner of ours, and that our goal is to try to make sure that we're engaging you all and ensuring that we take your concerns back and try to address them within the awards as we can. That if it's not prescribed by law or some other controlling statute, to do what we can to try to reduce the burdens that we're placing on you all, at least to confer with program office to ensure that we can reduce those burdens, to try to provide you all with consistency based on just getting feedback on what you're saying. If we're not being consistent, if you're getting, as I just was mentioned earlier, whether you're talking to HRSA or within CDC and you're talking to 2 different branches, that you're getting a consistent response, that we should not tell you several different things. It's about conference, or it's about how you could put in for a prior approval or something of that nature. The other area, just from a big standpoint, that it's really beyond our control. We understand sequestration is a big impact, and getting the awards out, we will put them out as quickly as we can. Just a matter of once we get the funding notification or the funding package is over, we will push those out and try to do them in a timely manner. We understand the impact and the effect it has on you all as far as being able to hire or what you have to do with staffing. So we're working to do that. And the main thing from my standpoint being here is just trying to make sure we establish that communication so that there's a flow back and forth. We can share information with you and that.
So let me ask you, John and team at HRSA, were you able to hear those comments?
Yes. Several things come to mind.
I'm wondering if you could share with us some of your thoughts, particularly as they relate to funding and state health agencies.
Sure. First of all, the consistency between CDC and HRSA, we think, is important. And to be frank, sometimes we have trouble maintaining consistency even within our operating division. And I'm sure that CDC knows what we're talking about on that. But fortunately, we all relate to the same set of departmental principles on how grants work. At least we have a common administrative manual to work off of, and a common structure for grants, using the project period method of funding, which means that Congress appropriates us money 1 year at a time, and therefore we give our grants pretty much 1 year at a time, even though we make a multiple year commitment quite often. Also, I kind of perked up on hearing the issue of funding science through categorical funds. quite a few years ago, I spent a little bit of time at NIH, and that's pretty categorical in a lot of ways. And we found that it was we did the best we could to give flexibility to our grantees, because research itself can be pretty variable and subject to outside influences as it progresses. And the mechanism we use to fund is pretty robust, I think, in terms of letting us, on one hand, keep a good eye on the funds and to be sure the funds are protected and spent in approved ways, yet still giving flexibility to the grantees to change with events as they progress through their research activities. And the fact is, we use that same mechanism to support here at HRSA all kinds of grants. One thing about HRSA is that we support a very wide range of types of grants, ranging from community health centers to research grants to demonstration grants, and we use the same basic rules and mechanisms to fund them all. One thing we can't seem to get away from, though, is that partly because of the changing nature of our grantees and their needs, that I don't know that we're ever going to be able to do away with variance, in how rules are interpreted sometimes and how they're put to work. I think what we have to keep in mind is the good of the grantees in these cases and allowing grantees to pursue their projects as approved. And so I think we'll continue to see variations in the way rules are interpreted, not only between CDC and HRSA, but even within our respective agencies. So those are kind of things that strike me. I had jotted down a few things after looking at some of the list of questions that were asked last year. Apparently this meeting was held in a similar vein last year. So at some point I can mention maybe some of the HRSA initiatives of things that we're doing in-house that affects you all as grantees and your concerns.
So hold that thought, John. Thank you very much. Let me scan the audience here. We have about 36 states, 37 states represented in the room. Is there a question on your mind as you've heard just these first initial comments that you would like to bring up? I will be expecting you to ask questions and entertain dialogue, so be thinking of them. Okay, Harry, would you come up to the microphone? We're going to ask each of you to come to the microphone and ask your question. And introduce yourself, please.
Hi, this is Harry Camdar from Ohio, and greetings to those of you joining us across the airways from HRSA and those of you right in front of us here that we've talked to already. I know that we have a session on sequestration tomorrow, so I won't belabor the point, and I know your knowledge is limited, but it would be helpful if you could explain to us how the process works before you find out what the cut's going to be. As I understand it, by April 25th, every federal agency was supposed to turn in an operating plan to the Office of Management and Budget, OMB. And then our expectation was that soon thereafter, states would be hearing about what their cut was going to be, not estimates, not general information, but final NOAs. And the reason I'm asking this is we have, as many other folks here have, October 1 start dates for grants, and that timeline is really shrinking for us to absorb that cut. So we're really concerned about that, and so if you could just comment on that, I would appreciate it. Thank you.
Was that directed to HRSA or CDC?
Yeah, we're going to start with
All of the above.
We're going to start with CDC.
Notice the silence at the end.
From our perspective, as you mentioned, yes, that did occur as far as the information flowing down. It did go through the program offices, and the program offices of the divisions had to make determinations as to where to apply those cuts. And that was all done on the programmatic side, and there were, quite honestly, just adjustments as they went back and forth, looked at it. Some programs are funded by more than one office or another federal agency. As funds was being, as they were determining whether they were going to fund it or not, constant adjustments had to be made to those numbers. So unfortunately, we were going to send out letters with estimates on it, but we knew that once we did do that, it was going to create some problems if you built around those estimates, and we came back and did some additional cuts. And quite honestly, it was probably the best, because we've seen up and through last week where there were adjustments where we had received packages to go forward where they were pulled back, and so that they're doing some last-minute adjustments to them again. So, as I mentioned earlier, we will publish or put this information out as quickly as possible. We understand that timing is a concern, but it's really driven based on program and as adjustments come to them and how their percentages are being applied.
Yeah, I think HRSA has done something very similar. I was thinking at the outset that I need to mention that, you know, sequestration is, I've been in the government for a few years, but this is frankly the first time I've encountered anything quite like this before. And the Office of Financial Assistance Management within HRSA, initially, the first thing we did was meet with each of the individual bureaus and discussed a few themes. And I also, as has been said, a lot of this has been left up to the individual bureaus to actually execute. But several themes were struck, and that is, first of all, the anticipated cuts we saw as being likely not to be introduced to a degree where they're going to hurt any given project to the point that the project can't be carried out. We were anticipated manageable cuts that would have to be applied to grantees in terms of getting ready. And this is the early stage of the discussion. And so going from there, the other themes that came out were the matter of equity in terms of we didn't want to be arbitrary and introducing variations in those cuts, that they're going to be equitable across the board, and have nothing essentially nothing to do with performance except in extreme cases. And so far we've been sharing information as we had it, and we're not satisfied with all the information we have at this point. And I'm sure that there's a lot of questions remaining out there with the grantees. HRSA in general didn't see any programs being terminated strictly as a result of sequestration. There's probably HRSA-wide, there's at least one program that isn't going to get funded this year, but it's not as a result of sequestration per se. It is a budgetary concern, but not a sequestration. So that, I guess, was the good news. The other thing is we've been keeping our ear to the ground with regard to our existing grantees, and we've asked all of our grants management specialists here to report in. I send a note out every week asking, I want to hear any reports that are somewhat, reasonably substantiated that you've got a grantee that's really in trouble as a result of all this. And so far the results have been reasonably gratifying. And another thing we've been doing is, but that's really more part due to the continuing resolution, I think, than the sequestration, is the issuance of partial awards. This has been a tricky process for us. For a lot of our grantees, instead of getting a full budget period, 12 months worth of funding, we'll fund them proportionally until we know more, and then we'll send another notice of award out, hopefully before the first set of funds has run out for any given project, to continue them along until we can breathe easier, until we get our allocation, not our appropriation. I'm not a budget person, so I have a hard time with these issues sometimes. Until we get an allocation that allows us to move ahead to continue to fund these grantees and hopefully keep them going until we can actually fund a full budget period, and everybody knows where they are at this point. I'm sorry for this vague, rambling response, I guess, but it's essentially all I know at this point.
Well, I think there's some head nods that this is somewhat helpful, so thank you, John.
I was just going to add some perspective from the program side, Harry. What we experienced is the sequestration planning initiative started before there was really firm knowledge around what the PPHF numbers were going to be. And in our particular office on the program side, PPHF and the numbers that they ultimately are, and we ultimately are allocated, are intimately related to our base, as we use some of those PPHF funds to fund some of our intramural, particularly S&B costs. So that exacerbates the delay and the need for more planning. So it's a complicating factor that fits into the equation. With PPHF here now and with firm guidance in place, that question's been answered, and I think we'll be, from the program side, we hope to have much firmer information very shortly.
Is there a follow-up question from anyone in the room here on sequestration or the kinds of explanation you've heard? Please step up to the mic. Thanks.
Yes, Ed Cal from New York. John touched on part of the. Ed Cal from New York. John touched on part of the question that I had. When there is a continuing resolution, Congress doesn't pass an annual budget. Is there a policy, or should there be a policy, on when agencies provide funding for the states? I say that because there does seem to be a wide disparity between when some funding for some grants are received and when funding for other grants are received.
Well, with sequestration, we're very cautious. I'm sorry, with continuing resolution issues, we're very cautious about not exceeding our rate of expenditure from the previous year. I mean, the marching orders are that at any given point on the calendar, we can't be spending our grant funds any more than in terms of the proportions that were spent last year at that time, and it's really, we're extremely rigid, and this puts a real squeeze on our projects. And we've because the sanctions on HRSA and any agency that exceeds it are pretty severe when it comes to a continuing resolutions. And we've been through a few continuing resolutions. And it's not my sense that the CR provides an opportunity or is causing any differential favoritism, if you will, to funding one set of grants versus another. We're not looking at those grant programs any different than we did before, except we're having to dribble funds out, if you will, at a very, very measured rate. And one phenomenon that it does seem to cause when we look across the whole agency is it slows the whole process down, because the whole process of getting funds out has to be restarted periodically until we finally get a budget. So what the grantee sees is a squeezing of the funds flow. They're not coming in time, the funds that are coming, and we understand this causes discomfort among the projects.
From CDC's perspective, there's really no particular, it's really driven by the program office as far as their funding priorities as to which they decide to fund first, and that's just being done based on where they believe the dollars they have, how they were funded last year. As was mentioned earlier, we're allocated so much each quarter of the fiscal year that they have to stay within, so that they look at from the perspective as to how many of the grants or what's coming due or what's the next project period. What do we absolutely need to fund at this point in time? They try to make those dollars work the best means possible. I can bring back and ask the question, but it's my understanding that it's really more based on timing and risk as to what's coming due and what that particular program that is coming up.
And I could offer one thing, some perspective on here's what the risk amounts to for us in program regarding earlier fiscal year awards, initial awards. I mean, obviously, John brought up a good point, the apportionment issue. You're facing a difficult situation right out of the gate if you didn't obligate those funds in the quarter that you wish to do this year. You didn't do that last year. But perhaps a bigger risk, I want to circle back to the PPHF funding. There's a unique aspect to that. It would be ideal if PPHF funding were authorized for obligation from October 1st through September 30th. In our case, last year, PPHF funding was authorized from January 1 through September 30th, including S&B, reimbursement for S&B costs. This year, it's April 1st through September. So right off the bat, there's a variable there. In my program budget, that equals up to, could be as much as $2.8 million one way or the other that I'll have to pay out of my base versus maybe have to pay out of PPHF. So if you fast forward to August, September, when we're really looking closely at planning our apportionments for Q1 and Q2 in the following fiscal year, it's a huge amount of risk. And with anti-deficiency concerns, there are questions around, planning, having a virtual plan that includes making these awards earlier in a partial approach as you described. So the uncertainty about PPHF in this case is one of the contributing factors that makes it difficult to try to move up those obligations, if that makes sense.
Great, thank you. Other questions on CR or sequestration in your mind as you're sitting there? Please step up to the microphone. Thank you. Introduce yourself.
Doug Axelson from Rhode Island. I'm concerned because I heard him say that the expectations are not being reduced with the sequestration coming through because they don't think it'll hurt programs. And depending on when we get notified of the cut that's coming, it could impact the program greatly with the remaining 3-4 months we've got left in the year. If we don't hear until July that we have to reduce something that was awarded to us last October by 5%, that means that we're looking at basically shutting the program down almost when we get to the point of, trying to make up the difference. Because most of us, in fact, I've only heard 2 states that got increases, most of us don't have any general funds to pop into the breach to solve the problem. So I'm concerned that there's no expectation, or the expectation is the same that the program will continue as usual, because it's hurting us now, not knowing if we can hire. And in most cases, you need people, boots on the ground, in order to make these programs work. So if you're delayed in hiring, or if you're delayed in setting contracts out with the vendors that you use, that's got to impact the programs. And I think the expectation that programs won't be impacted is a wrong approach to take, but that's just my opinion, I guess.
Comments from our panel?
I hope I didn't say that. That's my comment.
And HRSA doesn't remember saying that either.
I wrote it down. You said it.
I guess the sentiment is clear, though, that there's personnel actions that have to take place. If this is dramatic, you have union obligations if you're in states with unions with regard to notification, and I just don't know how that's going to be managed. And maybe somebody from the audience can describe to us how they're going to try to manage those notification deadlines with no money to work with.
I always hate to hear a frustration, especially when it's so broadly felt, and not try to address a solution right off the bat or thinking around solutions. So, one of the things that I wrote down here is that one of OSTO's charges is the whole communication and liaison aspect that we can provide. There is at least, with the acknowledgement of this issue, an opportunity to raise a discussion. There's an opportunity to plant points. It may be more timely for October, November, after there's been a closeout and there's an ease in things and there are receptive ears and there's time to have these kinds of discussions. But I don't think that we should simply leave it at the frustration. I'm very clearly picking up the details and the specifics on what you're putting out. And I think rather than acknowledge them and say, well, what a pickle, there are things that we can do, and I think it starts with discussion. And that can lead to championing, that can lead to education and leadership. So I would like to, I feel confident speaking for Dr. Monroe and OSTOS in that I think we can absorb that into the liaison role that we play, and we should start perhaps getting more involved in this group and addressing those issues.
Any workarounds anybody wants to talk about, or just something else? Go ahead.
I think we all kind of recognize. Oh, I'm Abby from Minnesota. Is this on?
Yep.
Yeah, okay. And I think we all kind of recognize the pickle you're in, and so we can acknowledge some of that. And I think what we've been trying to do is figure out how we would rapidly respond. I mean, we're expecting there's going to be some moment in time when the floodgates open and suddenly all this information is coming to us. But one of our challenges is there's not much consistency in how the the information actually flows to us. Some we get copied in our financial office, some go straight to the program officer at our level. We've noticed a real difference in the different federal agencies and how the communication's been flowing. And so one of the things we're trying to figure out is when those floodgates open, what is the format that the information is going to be in? Where do we watch for it to come into our department? And is there any discussion, at least in the HHS agencies, about trying to do it in a consistent manner? I'd say our drinking water information in particular has been really hard to follow, which I know is none of your problem, but it's still a bit of a challenge even for the agencies represented here.
I mean, HRSA tries several approaches when it comes to communicating with our grantees and our programs. I mean, we rely on the notice of award quite a bit. I've been at NIH and I've been at ARC and I've been here for a few years, and it seems that HRSA relies on its notice of award to include a lot of stuff, if you will, that terms of award and changes in award and terms and things to pay attention to and reporting and issues like that. We also use other approaches as we've gotten more and more into an automated awarding process. We find that we can sometimes facilitate some quick communication just by going through the database and the people that run the database to send blast emails, if you will, and notes out to our grantees. If we need to communicate something that's clear enough to a particular set of grantees or programs or activity codes, as we call them. That has worked pretty well, too. We've used webinars and assistance kinds of mechanisms like that quite often at the different bureaus within HRSA. Those are very effective. I'm a little suspicious of them because you don't always get everybody using that kind of an approach. But when you do come together that way, you can probably get a lot of information and a lot of clarification taken care of because you've got a potential for a dialogue. The flip side of that is you don't get everybody, and it leaves those that participate in that kind of a thing, with a leg up on those that do not, which is a little bit of a problem. So we have various approaches we use, and it seems like the bureaus themselves, within HRSA, each have their own folklore, if you will, and ways of communicating through their program offices. Some of them stage regular phone discussions among a particular set of grantees or activities that the grantees are wise to subscribe to and participate. And that works. That's an informal kind of thing in my view, but that's effective as well. In general, I think that, if you're on the receiving end of a grant, that the position you ought to take is not to be passive about communicating both with program staff and with grants management staff. That's something, I'm sure there's frustration in many cases because you may not be talking to the right people sometimes. And just between program staff and grants management staff, you can get different answers because it's a complicated process, and it isn't always, the facts don't always come out, but you need to talk to the right people. Basically, if you're going to be talking policy and the funding of your grant and prior approval kinds of things, you need to be talking to grants management. And on the other hand, for the projects and the progress that you're making on your projects themselves, you need to talk more to the program staff. That's the basic rule, but then there's variations on that theme quite a lot. And I notice at HRSA, even more so than when I was at NIH, at HRSA, there's a lot of crosstalk between the two. You'll find program staff talking grants management stuff to grantees and vice versa with grants management people. The trick for us is not to be isolated between us and our program staff. Because if we stop talking to each other, that's, I think, when you start getting a different answer, depending on who you talk to when you talk to HRSA. So one thing we try to do over here is have an ongoing dialogue and cooperation with our program staff so that we stay on the same page.
I'm unaware of any coordinated effort across the department as far as sending out any information, but as was just said by our HRSA counterparts, pretty much the same thing, that what we've asked is that the project officers doesn't hurt to contact your grants management specialist. The only concern we do have there is that as information changes, as I mentioned earlier, it does change quite a bit. That our concern is that we give you two different sets of information, or something may be outdated based on an earlier discussion. Things literally are changing every couple of days, just trying to make sure that we're getting you the most up-to-date information. But the goal is to reach out to us. There is no other formal process. We are not, other than the NOAA. As I mentioned earlier, we were going to do letters, but because those numbers were changing too much, we didn't want to cause the problem of folks planning on using those letters and finding that those numbers were going to change and just creating additional problems for you all. So the best thing, as advice I can say, is just make sure that if your project officer isn't reaching out to you, make sure that you're in contact with them or the grants management specialist that's managing the work.
That last comment about project officers reminded me of some positives, and John, we'll get to you in a minute, but I'm aware that OSTLS is doing some outreach with project officers, and then Terrence, you might want to talk about the new grants assurances project.
Well, I'll just say a brief moment. By a show of hands, has anyone in this room been involved in the Technical Assistance Support Improvement Initiative called TASI at OSTLS? It's an ongoing initiative to basically put a curriculum to identify the weaknesses the project officers have from the perspective of the states, put a curriculum and a workforce development structure around that to basically create a class of project officers that have the competencies that you guys find are priorities and be able to deliver the kind of collaborative support and interaction that you guys require. That is a key component that's a key program at OSTLS. I think from the PGO side, I'll defer to you for
I'm not sure if you all are aware, but we recently, CDC recently launched a website where the assurances that are required to come in when you submit an application with an FOA, that we now established where you submit it one time. You don't have to submit it with each and every award or application now. You submit it once, we post the information, and then we'll pull that information so that the purpose of it is to reduce the amount of paperwork you have to submit into grants.gov to get to us, so that you do it once a year. It's an annual requirement, and so we're trying to find ways of reducing the burden as far as the amount of paperwork that you have to send or documentation you need to submit through grants.gov. It's up and running, and if you're not familiar with it or if your folks have any problems, just get with me afterwards, and I'll make sure that you get the right link so that you can get your information into it. But we started it about, I guess it's been about a month and a half now that it's been up and running, and if you have any questions, it's just a matter of trying to do what's there. Once you submit an application, we'll pull it down and tie it to your paperwork to make sure that it's linked, that it's active and it's still current, and we'll move on from there.
How many of you are aware of that? So that's a very big change. So we will send out that link to you after this meeting and make sure you have that. You also talked about now the standard FOA template, which is also a new development there.
Right. Once again, it's one of those things where we're trying to reduce and standardize the structure and the format and what information is there, what we're asking for. We're trying to actually, instead of trying to shrink it down from the 80-plus pages where you have all the links, we're trying to just identify and do similar to NIH if you've done anything with them, where it links you to certain other documents or where the ARs and other activities or other listings of information are left, so that as you pull it down, it's simple. We're standardizing it. We're trying to make sure it's much more concise in what it says and reads easier for you to be able to follow through and apply for you and any other potential grants you have.
And I can speak from personal experience about this new standard FOA. The ASTHO Senior Deputy and the Advisory Committee to the Director both advocated for the single FOA concept, and the Office of the Director and PGO and everyone pulled together to make this happen. It's on 25 pages. It's a standard format that every center is going to be using going forward. Well, ASTHO's continuation application with CDC as a partner was the guinea pig. So we asked for something and got bit by it. It is no easy task to take where you we're able to use more detail on 80 pages to shrink that down to 25 pages and set the stage for a cooperative agreement going forward. So it's really nice, and that you'll see a standard format going forward for all your programs from CDC. But it still requires careful editing, careful use of language, and precision with regard to the point system. And Katie was our lead at ASTHO and did a really nice job of matching up the structure of our response to the point system that they were using. And so, in fact, Katie, at some point, we might want to talk about that online with the CFOs and just talk about that structure and relate that to the standard format, because you could use that structure, that approach we took with your applications going forward. There's no sort of secrets involved. It would just be explanatory and descriptive. You could take it for what it's worth, but it's something to think about as we go forward. So we'll make sure you get the assurances, some sense of information about the standard FOA, and then maybe even have you, Katie, describe sort of our approach to that standard FOA. So, John, let me go ahead.
A question on the FOAs. In preparation for this meeting, I talked to a number of my program staff that are responsible for filing the FOAs. And several of them come back and said that it seems as though the time limit is being reduced. What had been 8 to 12 weeks is now, in a number of cases, being reduced to 4 weeks. Is that a policy? Is that something that's just an aberration? And also, when we're doing a new form, will it be a policy, a set policy that will be a set amount of time for all applications?
There's a minimum number of days that we're required to have it posted, so I'm not sure if it was just based on timing, based on subsequent follow-on of awards. So I can talk with you specifically afterwards, but no, we're required to have a minimum number of days to have it out there. In many instances, we may let it run longer than that, but I'll have to go back and check. I'm not sure why they would have done that, other than the fact that it just made the timing based on some subsequent award or something, or the expiration of an existing award, I should say.
As far as HRSA goes, I believe the department requirement is at least 30 days that an applicant should have to, once an announcement is posted, to apply. HRSA usually allows a lot more than that. And frankly, over the past couple of years, I'm not noticing that there's a tendency to move toward a shorter time period. Depending on the complexity of the proposals that are being developed, it's not uncommon to hear complaints that we're not given enough time. But generally, if I were to judge on average for our project grants, we're probably allowing 60 days, at least in most cases. And I'm hardly seeing any FOA drafts that are down to 30 days. Most of our program staff recognize that applicants need a lot more time in most cases than 30 days, unless it's the simplest research projects. Going back a little bit to the earlier discussion, as far as announcements, my sense is that HRSA may be lagging a bit behind what CDC is talking about in terms of the single FOA, but there's plans afoot to work towards something simpler here as well, simpler and shorter. I'm hoping it works this time, because over the years there's been a number of starts, across the department for a more streamlined approach to announcements and things. One thing we have done in recent years, for non-competing continuation grants, we no longer require, in most cases, an application for a new budget period for something that's already been approved. What we rely on is a progress report. And again, it's debatable whether that progress report is, in some cases, any less work than putting together a whole application. Unfortunately, we don't want to revert back to that. But we think we've simplified the continuation application process a bit. And we hope to do more of that.
John, I think you alluded to other improvements that you have underway. I didn't know if there's anything more you wanted to add.
Well, there's things to either improvements or things to maybe remind your audience of, as far as I know last year there was some questions about flexibility with existing grants especially when times are particularly tight. With most of our project grants, grantees should know that there is flexibility within your budget, that a grantee can generally re-budget up to 25% of that grant for that budget period without prior approval from HRSA. It's not totally flexible. You can re-budget it into other approved line items on your grant. So that gives you something to work with without having to impose the delays of getting prior approval. Also, with a lot of the health professions grants that we issue, we allow them expanded authorities, which means that in some cases they don't have to ask for prior approval for certain things. Like for health, this doesn't apply to all of our grants, but it's an old approval that was given by the department several years ago to health professions grants, very similar to what's taking place in almost all of the NIH grants. For example, if you have an unexpended balance at the end of a budget period, you can bring that forward into your next budget period. If it's less than 25%, you can do that without getting prior approval from HRSA. Other non-training grant, non-BHPR grants don't have that benefit. There's also a few other maybe more obscure things that a grantee could do with such prior approval authority. But for our grantees that have prior approval for those kinds of things, expanded authorities, if you will, it's written right on the front of their notice of grant award. And that applies to most training grants by far. We're also focusing on doing a better job of closing out existing grants. And we're trying to, pick the low-hanging fruit, if you will, for those that are kept open with very little money in them or with no money in them. Closing them out is something I think historically the department hasn't paid as much attention to the back end of the process as they have to the front end, probably due to lack of resources. But HRSA is motivated to do closeout on a larger scale than we have in the past. Why? Because it costs us money to keep these accounts open. The payment management system charges us a fee. And secondly, sometimes it leaves money just sitting for a long time. And in these kinds of times, those funds, if they're not going to be touched by anybody, need to go back to the U.S. Treasury and put to other use rather than just sitting. So we're taking more actions to try to close out and make it, if we can, make it easier on our grantees to close out and reconcile a particular document. Even for an ongoing grant that maybe have a series of competing continuations going on, we'll reach back and begin to close out some of these old accounts. And we may be getting in touch with grantees, about money that may be several years old, and determining the final disposition of that. So those are the kinds of things that were coming to my mind in terms of what we're working on.
As was just mentioned, this is part of the effort that's underway just within HHS. We're trying to remove as much administrative burden by these old contracts, or old grants that are open that require you to maintain certain paperwork or track certain information. The quicker we can get those closed out, if it's of a benefit to us, but however we also view it as a benefit to you all to be able to clear your books, get information cleared out, and move things on. So that's part of the effort from our standpoint. As mentioned earlier, I believe that was one of the frequently asked questions last year, was mentioned about the non-competing relations, so that we're trying to reduce means or the burden, once again, as far as paperwork and things that you need to submit to us. If we're looking for ways to minimize the impact on you all. If we have the information readily available to us and it makes sense to use it, it's our goal to try to do that and still meet the requirements that we have as far as documentation and everything.
Yeah, another thing that comes to mind for us is that we're also trying to systematically take a look at the prior approval requests we have from you all, from the projects, and do away with those that have been, dispose of those and take care of those that may have been sitting too long. Responsiveness is something that we're aware of that we don't always do a good job of, frankly, in terms of responding to your needs fast enough. And part of this is due to resources and issues like that, but we're trying to do a better job of getting back to you and resolving your questions, especially those kinds of prior approval requests that are in regulation, that are due to get a reasonable response from us, whether it be a carry forward of unexpended balances or a rebudgeting or a change of project director or whatever. We want to play catch up with a lot of that so we can be of better service to the grantees.
Great, thank you. Let me pause here and ask if there's another question or an observation or a thought that's occurred to you in the audience here that you'd like to walk up to the mic and share.
Don't forget, we also have Donna, and Robert.
How about our colleagues or CFOs on the phone? Do you have a question? Okay. I'd be interested in across DHHS standardization of funding kinds of strategies. And first question is a simple one. Is there a standing group of fiscal officers or fiscal interested offices across DHHS that meet with the idea of looking at efficiency and effectiveness? That's sort of the first question. And then the second question would be in the areas of carryover, grant synthesis, and matching federal interests with state interests. And what I mean by that is we heard some comments last night about states doing state health improvement plans. I know we have a national prevention strategy, and so that sort of overlays HHS and some of the programs. But it strikes me as really valuable to have our funding mechanisms link a federal prevention strategy and the state health improvement plans as a way for programs to really look at what they're putting out in their FOAs. So I'll sort of go backwards and repeat what I said. Is there a cross-DHHS effectiveness and efficiency work group? And is there any conversation going on with regard to standardization of carryover, sort of synthesizing grants? And you could think of the surveillance requirements. You could think of the health information technology requirements. And then this question of alignment of health improvement planning.
I'm not aware, on my level of the program, of such a collaboration on this. I think for the PGO for the bigger picture. I will say that I am extremely interested in finding out specifics around the challenges that the states have with carryover funding, particularly as it relates to categorical funding, particularly as it relates to the timeline challenges that we've been talking about, getting an award on X date when you've only got, you've got X amount of time before October 1 comes around. So I really would welcome a discussion and some specific examples of what can be done to, what an ideal situation regarding carryover would be. And financially, I'm actually very interested in finding out what the actual actions that are taken, the granularity that the health departments have in the assigning of costs to the specific dollars that were awarded, particularly if there were different funding streams involved in the award. So I hate to answer a question with an invitation for more questions, but I would welcome that discussion.
And I guess from just a limited response, that yes, HHS is looking at certain things. I know that there was a recent work group that just looked at the issue of terminology across grants within. We're switching some of our guidance from the ADAM to the GPAM, and just looking at terminology and how it's used and how those terms are being applied. And we're using them, we're talking with grantees and applicants. So there is a drive to try to standardize as much as possible so that there is some consistency or that there's efficiencies gained based on doing certain things like that. Now, there are some other priorities that they have that they're working, but I would say that there are folks that are assigned to these work groups, but I've only been in this acting role for a few weeks now, so I'm not up to speed to all of the various work groups that are in play right now. But the one meeting I did attend, I know that is an issue to drive towards some level of efficiency or effectiveness, not just within HHS, but across the
This is John. I know there is a departmental work group that meets periodically. There has been one for years. It's composed of the chief grants management officers. It's not a group of fiscal officers or financial, but it's grants management in general. And frankly, I can't remember the name of it. I don't work at that level, but they meet periodically to work toward consistency. And there's competing interests. HRSA is large and CDC is large. We also try to focus on consistency within our respective operating divisions as well. Now, as far as carryover, are we talking about the carry forward of unobligated balances in a given project from one year to the next? Is that the type of carry forward we're talking about?
Yes, that's what I was moving at.
Yeah. Well, I mean, our sense, we're very individual project oriented here, save for certain programs like the Maternal and Child Health Block Grant Fund under Title V of the Social Security Act. I mean, that's pretty broad, but by far most of the projects we support are individual projects. And the unobligated balances remain with those projects, of course. I suppose in a perfect world, we refer to it affectionately as UOB. In a perfect world, there is no UOB. In a perfect world, competitive grants are perfectly budgeted, and at the end of their budget periods, they're down to zero, and no money remains in the payment management system, and we can efficiently fund them continuation funding before their budget period starts. And again, at the end of that budget period, there's no unobligated balances. Well, that's the perfect world, and that's not really the way it works, of course, because we know you're subject to a lot of changes. We have a lot of grants to universities and others, and we notice the trends too in awards to cities and to awards to states. There's of course a tendency for more UOB to occur at the end of a budget period because states have to get their contracts up and working, especially that first year. And we do as best we can to allow for those kinds of things when we design our announcements. One thing I've always suggested to program staff in putting FOAs together is anticipate those low startup costs in the first year when you put the funds out there. Don't, flat funding from one budget period to the next is, frankly, I think seldom a good idea, but it happens a lot. And sure enough, with that first year, you have unobligated balances. But that's for, in an ideal situation, that's for work that hasn't been performed yet and needs to be performed. So it'll be performed in the second budget period. So, in the classic carry forward UOB situation, we allow that carry forward to take place, and hopefully the grantee can catch up with the approved work in that second or third budget period and everything comes out right. That's, once again, if things are working well. There's tendencies, I realize there's competing tendencies between grantees and the federal government, of course, that in terms of how you view unobligated balances. The default option with UOB in cases where there's just money left and the work was performed appropriately in that first budget period, and we use that money as an offset, an offset to the next budget period award. And the way the grantee views that is as a budget cut, which is not surprising, of course. From our point of view, we're essentially funding the grantee at the amount that it needs, but there can be differing opinions. I mean, the ultimate solution, I think, is to do away with unobligated balances so everything works so efficiently that it doesn't happen that way. And I don't know how long we'll struggle with that in the long run, but as long as we keep our eye on the fact that we want you to be able to pursue your complete project as approved, and we don't take actions when it comes to requests that you make that keep you from doing that, I think we'll be all right. On the other hand, there's going to be times when there's just an over-budgeted project, and it resulted in unobligated balances. So I think you know, we've still got to preserve the option of using offsets in cases like that.
Jim had to take a call that he was expecting an important call, so I'm filling in. He's got some great notes here, but I don't have the background to properly interpret those. I do know that our planning group wanted to make sure we had HRSA representation on the phone at this meeting this year, and that this is kind of a newly emerging area among some states, and just wanted to make sure that everyone had the opportunity to ask questions about opportunities with respect to HRSA funding based on some of the conversations we had earlier this morning and things that have been percolating in the States. So maybe this would come down from the lofty cloud level to the nuts and bolts, you know, about allowability, cost allocations. Yes, Harry?
Is that for CDC or for HRSA?
Harry's going to ask you a question, I believe.
Okay, I'm back for round two. Harry from Ohio. Since nobody else was up, I thought I'd take advantage. This is in reference to future funding streams and how you plan to dole out the money in the future. We know the sequestration will end someday, and we'll be back to the good times. I'm trying to instill a bit of positivity here. Will you be looking at ROI? Will you be looking at whether states are accredited? Will you be looking at audit findings for prior years? Will that all play into the future? The reason I ask this is that we are already on this path with our local partners. By the year 2018, we expect our local partners to be accredited. We expect regionalization of grants to have occurred by then. We expect our local partners to have dwindled down in size from 125 local health departments down to at least 88. We have 88 counties in our state, and preferably lower. We're pushing shared services solutions so that we're able to leverage deficiencies in one part of the state and use them for others, and so on and so forth. So I'm just curious about that, and tied with that is the whole question about funding formula. You know, is it disease incidence based? Is it population based? And what this does is, if it's population based, just an example, it goes to metro areas of 3 million and more, it pretty much eliminates 95% of the country. And it comes to the city that we're in, Chicago and Philadelphia and LA and New York. So we are very sensitive to that, especially in Ohio. We have more metro areas, and they just don't happen to be super large, but we have needs. We have all kinds of different needs there. So with that, I'll head back to my seat and let you answer the question. CDC first, I guess. I don't know, alphabetical order.
I might want to spend the night formulating a response to this and send it to you in writing tomorrow. Thanks for that question, Harry. That's all right. So let me deal with some of the easy answers here first. As far as population-based versus disease and incident-based, OSTOP is a cross-cutting office. It is an infrastructure and capacity building component. So I want to say that I can't speak for my colleagues on the program and intervention side. However, the NIFI cooperative agreement that we've awarded is a good example of an acknowledgement that the need is there in the rural and smaller populations, as well as in the MSAs and the larger metro city cash, it's sometimes been called. This is the first round of NIFI funding. This is the first 5-year FOA. I think we're definitely hoping to set precedent here that it will be a broad look across the entire population health environment. Now, I also don't want to imply that the funding distribution scenarios that occurred in this first 5-year FOA are going to be standard. I don't think that is going to happen at all. But
But it's important to recognize that both population environments areas are represented in that FOA. So the short answer to your question is, from our perspective, that's going to be the smaller urban areas, the smaller rural areas, I think, are going to be a growing part of the discussion. I would expect to see that then become a bigger part of the discussion. As far as as far as accreditation, to get back to ROI. To answer your question, absolutely. I think it's inevitable that ROI is going to become more and more of an absolute determining factor in all of this. I think regardless of whether funding increases or decreases, what we're going through right now is going to make us permanently leery of, it's going to make us suspicious of the flush times and make us pull in even more in the tough times. Dr. Frieden, clearly, he's laid out 3 areas of focus as funding continues to narrow. Funds will be directed to more narrowly defined priorities. The last 3 that he's given are improving health security at home and around the world, better preventing the leading causes, death, disability, and injury, and strengthening public health and healthcare collaboration. So I think no matter what happens in the funding environment, we've learned from where we are now that we need to be prepared to narrowly prioritize. And I think the way that you do that is you seek and demonstrate ROI. So I think it will be a critical component.
Right, and there is discussion, as you mentioned earlier, from the tying ROI, past performance, and other activities, other related criteria to that. Because the goal is that times may get better, but then, as was just stated, they may not. And we just, from the federal government's perspective, is that our goal is to proper stewardship of the dollars is to get those dollars out to where they make the best sense or best use, and we see results being driven based on that, on those funds being awarded.
I've heard rumors certainly of the accreditation process serving as a proxy for your qualification as you're submitting an application. So once you go through the accreditation process, you meet certain prerequisites in terms of the infrastructure for handling a award. You wouldn't necessarily have to rewrite that with every application. Does that ring a bell to you, Randall?
I'll be honest, that's actually something I'd like to take back to OSTOS and try and get a more formal, a broad response on that. But it's inevitable that accreditation will probably become a formal part of if not the criteria, then the considerations that are involved. But I will come back with a response from our team.
Okay. Another hand up here? Yes.
I'm Sandy Breitbart from Wisconsin. And the question I have kind of crosses programmatic and fiscal issues, but a number of our programs have been told that they can use some of the CDC funds that they've received for other kinds of activities, so related to accreditation or for ACA kinds of activities in terms of public health working with healthcare, for instance. And so from a fiscal perspective, I was wondering if you could give us a little guidance in terms of the kinds of things you'd be looking for, what would be appropriate and would fall under those parameters, so that when we maybe use some of the funds for a program-specific grant for what may not be typically the use that's been made in the past, it's not narrow and just program-focused. How far can we go? What are some types of examples that maybe come to your mind in terms of what's appropriate spending?
Honestly, I'm going to have to take that back because I do remember that discussion, but my concern is that, as I said, there was quite a bit of debate on that, and at that time we were transitioning offices, so I didn't necessarily get the final answer in regards to how that could happen. I know that there was a discussion as to whether it was explicitly stated as to whether you could use funds to do that, or whether it was implicit in the fact that you could do it based on what's being asked of you. And quite honestly, I don't remember the final answer. So what I mentioned to the ASTHO folks, that I will take this back. I will share that information with them so that they can disseminate to everyone in the room, so that you'll get our response back in writing. And so my apologies for not being able to address it now, but I hate to give you some bad information and have to come back and tell you, oh, never mind what I said before. So.
Yeah, so I think those discussions, as with the prior point, are taking place, but the final status we're not quite clear on. Yes.
Doug Axelson from Rhode Island again. Just a way that we've kind of addressed that when I've been told that information is I have them contact not only the project manager but the PGO and get it in writing that we can go ahead and do it. Once I have it in writing, they can do what they want.
And I will follow up to make sure that that is the formal process.
Like you mentioned, there's different interpretations depending on who you're talking to.
I'm Kate Furman. I'm with Georgia, and I participated in a meeting at CDC back in February about the sexually transmitted disease grant. One of our concerns is that the CDC officer was saying that the CDC funds could no longer be used for treatment in the upcoming grant year, and we're very concerned about that. And just to broaden the scope, do you see that as kind of the first kind of ACA impact? Because ACA was cited as the reason for making that change, and do you, and I want to ask HRSA as well, do you see the funding going away from treatment and into other types of things like surveillance? And as a state who's not expanding Medicaid, I'm extremely concerned. Thank you.
I think from HRSA's perspective, we don't see that trend. We support the HIV and AIDS Bureau, for one thing, and that's got a heavy emphasis on treatment, and also our programs of community health centers. And I don't see any shifting away from treatment, frankly, for the purposes of surveillance.
Thank you. That's good to hear.
But again, I don't have my finger on the pulse necessarily of everything, but that's been my sense from a grants management perspective.
Right, and I'm not sure what was the driver behind it, unless they found something or they're, once again, it gets back to interpretation of what the language in the ACA or how the FOA was written that they made that interpretation on. So once again, here, I'll follow you after specific information so that we can get you an answer, and then we'll share that as well with everyone. I just want to make sure I get the specifics.
Yeah, because there were several other states that participated.
Again, in keeping with the questions about the future, we were wondering about one. We're wondering if the model that's occurring with the coordinated chronic disease, let me get the acronym wrong, but the one where all the chronic disease programs are being kind of lumped together into a little more block, if that model is going to be applied to other areas around the department, and in particular, if it'll be applied in the same way. We're very supportive of that approach because we've been trying to move in that direction in our state. But the not knowing what we're going to get until the day before the beginning of the fiscal year is presenting some significant challenges for a state like ours that had a pretty significant program. And sort of the flip side of that is we're wondering if it'll happen in other areas. We've been looking at a more healthy homes model as opposed to separate sort of environmental health pieces, and I know not all of those are the departments represented here, but again, then our lead funding was cut, which is kind of the underpinning of that from CDC, and then it endangers money we get from other federal agencies. So we're just kind of wondering, is that model something that you're looking at in other areas? Are you finding it works or not? Kind of what's the thinking there? Thank you.
Well, and unfortunately, I'm not familiar with the model from the chronic side. We'll definitely go and put these questions to our colleagues and get back to you with a response.
I'm looking at Katie. Wasn't that what Julia was talking about, forming a work group on, or am I getting my coordinated chronic disease grants confused?
I'm not quite sure. She does do coordinated chronic disease, but I'm not quite sure what you're referring to.
But if there was interest in this group focusing on building the infrastructure of leadership around that.
Yes, possibly.
Okay. Anyway, if there is interest in that, I know either with this grant or a closely related one, ASTHO is spearheading an effort that actually wanted some CFO input on that model. So I'll get back to you, Abby, and if anyone else is interested, please drop me an email. Okay, so we got 10 minutes left, and Jim's back in the room.
There's bad news.
Any other questions? Then I will give it to Jim for the grand summation.
You guys are awesome. That's what I'm saying. Would you please join me in thanking our panelists here in the room and on the phone for their... Thank you, Randall and Terrence. And thank you, John and Jackie, for hanging with us through the phone. You do look marvelous, too, in your outfits.
Thanks a lot for the opportunity. We're sorry this was short notice and that we changed names on you at the last minute. But I really appreciate the chance to talk to you.
As do we. So thanks again.
If I may say, if you give me about a week to try to get the responses back to you, so that I make sure we do a quick turn on this. And if you have any follow-up questions, feel free to contact us through directly or through ASTHO. We'll make sure that we get your responses back.
I think a week is going to be okay. Just kidding. So thank you all again. Now we're at break time, and I'm going to hand it back over to Carl.
Great. Well, thanks again. Really appreciate our federal partners and Jim for facilitating that dialogue. Several housekeeping issues we want to touch on now. Let's see. Allison, do you want to talk about the dine-around option sign-ups? Oh, sure.
So this is your last opportunity to sign up for the dine-around because during the next session I will be notifying the restaurants of our final count. So once again, the sign-up sheets are out on the table by the elevator. And we do have a break, and you will need your name badge for the next activity. So if you left that up in your room, make sure you bring that so we can get organized for our roundtable discussion. Thanks. Thank you.
Okay, so again, the dine-around is we will be going to different area restaurants, and we have several options for you to sign up.
And I'm recruiting for sushi.
Other than that, we are due back. Let's just go ahead and make it due back as we planned on 4 o'clock for our roundtable discussions on cost allocation methods, recruiting and retaining staff, revenue development, implementation of ACA, and sequestration. So we'll see you back here at 4 o'clock.
Thank you. Please stand by.